because beforehand they didn't look at their face critically. As soon as you've operated on them, they're going to look at their face critically in the mirror every day till the swelling's gone. They're going to look at everything there, and they're going to do the same thing when it comes to teeth as well. They're going to lift their lip up and look in the mirror. And what we think is a good result may not be a good result from them. So we really need to be very good and address those. And then we see the situation, the no hope situation, where they've got a bunch of teeth in here which have got problems, and they've got periodontal issues and all that sort of thing. And then, this isn't the case for placing a single tooth implant into there. There's more a global approach that needs to be explained to this patient about, what's possible with teeth like this. So, ideal dimensions for a single tooth. In the upper arch, we want 7 millimeters of width ideally. So when we place that implant, we've got at least a couple of millimeters, labial and palatal. Interocclusal distance 7, and labiolingual 5. Bone quality, so in the anterior maxilla, they might have good quality bone in some people, and we might have poor quality bone in others. So if I'm going to place an implant there and it's poor quality bone, I may need to go back to a fallback situation where we have a 2-stage procedure, bury the implant for a while. Or if we've got reasonable quality bone, maybe I'll just do single-stage surgery and put a healing abutment on. Or if we've got really good quality bone there, maybe I'll place the implant, we'll take an impression and we'll load that implant immediately if that's appropriate. So there's a whole lot of different things that we may choose depending on bone quality. So we've got immediately delayed, 1 or 2 stages. We may need to augment, and then we may need to look at the aesthetics of this. And if we're going to do some soft tissue grafting, maybe we'll decide not to put a provisional crown on, or if maybe we figure putting a provisional crown on which is under contoured might help with our soft tissues and might help with our interdental position. So each individual case will be different. Standard of care for most of this, for a single tooth implant where you've extracted the tooth and there's good bone housing, maybe we'll get away with a PA or an OPG. If there's some question mark about the bone quantity there, then maybe we really need to be looking at scanning techniques with CT, and conventional medical CT are the ways to go. I think the advantages, and why would I choose CT over cone beam CT? Well, if I've got missing teeth in both jaws, I'll probably go for a cone beam because that'll scan both jaws at once. Through Medicare with medical CT, they will pay for 1 scan per day. So if you want both jaws scanned, then they'll have to pay, they won't get any Medicare rebate on the second scan. So then they'll have to go to the next day, and maybe the person doesn't want to go twice. So if I'm going to do some significant grafting in the maxilla, or if I'm going to place lygoma implants in the maxilla, then I'm probably going to choose medical CT because it gives better data, and when you put them into Noble Clinician, there's more bone data there than you'll see on some of the cone beam CTs. So there's different reasons why we may choose one modality over another. Radiographic templates are important. As I said, we have the situation where you might assume that there's a lot of bone, but it may not be in the correct position. If we've got a radiographic stent there and we can see the outline of a tooth on our CTs, then we can maybe make a better assessment of exactly where is the bone in the correct position or not. So we've got retained roots. So we may have the situation where you've got a decoronated root and the gingival tissues have grown over this, and we may be surprised to find there's still a root retained in that area where we thought there was a dentular space. Converging teeth. We've got some submerged primary teeth in the lower jaw. We've got minimal spacing here, and we've got a bridge over there. And we need to really know what's going on. We see this case with the lateral incisors, and at the crest of the ridge you think, oh, well, that's okay. They're in fairly narrow spaces. Our teeth are going to be small. That's normal. And you've got problems with gingival recession on this central incisor, which probably needs to be addressed in terms of some sort of grafting. As soon as we lift a flap in that area, we're going to get more gingival recession on that central incisor tooth, and that may not be a happy situation for the patient. They may consider that we've made that worse and need some treatment on that. And then we may take a radiograph, and we can see here that there's not enough space between the adjacent teeth. Even though these teeth were bonded together, which they should do, maybe these weren't. And we've got an issue here where we don't have enough space. If someone's gone through a period of orthodontic treatment and then they find out when their growth completed that they need more, they're very unhappy customers, and so they would need to go off for some more orthodontic treatment. So we really need to be very, very careful with that situation. And again, looking at the bulk of tissues, looking and see if we've got gingival recession. Have we got, that looks fairly bulbous situation up in here, so that looks a reasonable situation. If we've got concavities in that area, there may be enough bone to cover the implant. The patient may be unhappy about the concavities, so I always question them about them, and I say, I noticed that the gum's a bit flat in those areas. Does that bother you? If we place an implant in there, are you going to want that to look different than that? Do you want it to look more bulky? Do you want it to look like the other side? So I question them about, what are their goals when it comes to that, and then taking photographs, occlusally will give us some indication of whether we've got a flat contour on the labial or whether we've got an ideal contour on the labial, and whether we're going to need to augment or not augment. We may have primary teeth there, but no permanent teeth. And pretty much every time you see a situation where there's a primary tooth like this there, and there's been no permanent lateral or canine to erupt through there, the ridge will be narrow, and we need to CT scan these cases every time, because we can get fooled by how much bone there may or may not be there. So the ridge form is created by the eruption of the permanent teeth. If we don't have any permanent teeth erupt through there, then we're going to have a deficiency, particularly in the width of the jaw in those cases. So scanning is important so we can pick up any of those. So that's medical CT, and we see here this situation where there's a primary tooth, and then our implant's going to go on a different trajectory. So if we want to engage this bone correctly, our screw access is going to come through the front of that tooth, so we need to start our preparation here, place the implant, and then we may end up in that concavity. So we're either going to consider that we're going to need to graft the labial a little bit, or now if we use a conal connection implant, we can use the angulated screw channel to redirect that, and we can still have a screw retained crown. So here's the ideal placement. So we may use just a traditional way of tracing up a CT and using the template for that, or we may choose Noble Clinician. We can do that both ways. So I use Noble Clinician personally quite a bit for planning for cases. So we can see here that implant's going to go very close to the labial plate. If you're a really fantastic surgeon, you might be able to negotiate that ridge without perforation, or you may end up perforating that ridge labially. So I would say in a situation like this, you may consider putting a little graft on the labial of there just to increase that bone thickness there. When I've seen fistula formation in the past, when you've got if you've got very thin tissues over an area like here, this is where you'll see fistulas form, and that's because the overlying soft tissues are too thin, and the implants perforate or very close, to the outside there. So those sorts of considerations where you think it might be okay, I can get that implant in that bony housing, but in the long term we may see fistula formation if the tissues are really thin in those particular cases. So, study casts. So from a study cast we can make a radiographic stent, and from that radiographic stent we make a surgical template. So we can use the same radiographic stent for a surgical template if we wish, or make individual ones. And so this really helps us because we want prosthetically driven solutions, and so we want to make sure that we are placing our implants in the appropriate way. So if we have a look at this CT scan overlaid with the tracing, we can see there's some perforation of the labial plate, and again with this implant here we can see some threads exposed. I don't like that in the long term. Potential for problems with soft tissue movement over those threads, fistula formation and whatever. So we may consider to put a little graft material over there, and we'd put a membrane over that as well, so we can get some bone growth and healing in there. So it's a very simple type of graft, uncomplicated, and we know that we're going to have that problem before because we've done some appropriate planning. And then if we see a situation like this where there's more bone missing, so at the crest of the ridge we can see in this situation here we've got quite a bit of bone missing here. All right, and are we going to just be able to put some biowas over there in a membrane, or are we going to need something more substantial? So when we open it up, we see this, and all the bones on the palatal, all this is missing. This is the nasal spine here. So there's no way that we're going to place an implant in here and put a little biowas around there and put a membrane over that, and that's all going to be fine, because we're going to need a veneer graft in here. We're going to need some patient's own bone in there, and allow that to heal first, and then come back and put the implant in as a secondary stage procedure. So if we've done our planning, whether that's just conventional tracing like this or using Noble Clinician, we can avoid having some problems, that embarrassing problems where we need to close up or we haven't got the right tools to treat this case, or in some cases may not have the right expertise to be able to treat these cases. So looking at CTs, we can see on these a variety of problems. We've got concavities on the labial where the roots are, and when we extract teeth like this, there's only one thing's going to happen there, is this bone's going to end up even worse here. So I know when you see that I'm going to have problems with that. And we've got a variety of different size of incisive canals, and depending on how big they are, it may or may not interfere with our treatment. If that canal is going to interfere with my implant placement, I may choose to enucleate the canal and graft the canal in conjunction with implant treatment. And people say, well, is there a concern, there's nerves and blood vessels run through there that supply the anterior palate? I haven't seen a case yet where I've enucleated that where there's been a significant problem with numbness of the tissues in the palate. So we can safely enucleate those and make our implant treatment more predictable. So, if in doubt, we enucleate that. So what we do is inject deeply into the canal so we can get adequate anesthesia, because that canal goes through to the nose, and so we want to have not only the oral part of that canal numb, but we want to have the nasal part of that canal. So we raise a little flap and we incise the tissue and use an artery forceps or curettes to remove the tissue from the canal, and then we can fill that with whatever our favourite product is. It may be autologous bone, it may be a bit of xenograft, biowas, whatever. Checklists are important. Nothing worse than turning up to do treatment and you haven't got all the equipment there. We haven't got the radiographs, we haven't got the implants, we haven't got the prosthetic components, we don't have the right screwdrivers or whatever, and this stuff happens all the time. And so you don't want to be at a hospital out of your own clinic and all of a sudden you don't have the right equipment. Quite often we get calls halfway through and I have a little bit of stock and people ring up and say, oh Brent, can we borrow this off you because we've got a patient on the table and I've got a wide platform implant but I can't get that in, or I've got a spinner and I want to put a wider one in, or whatever like that. So you want to avoid these embarrassing situations and have a checklist out and make sure that your staff go through that. And I always check stuff, my staff put it out, I always check stuff permanently, read every individual thing to make sure that we've got all the right things. Surgical templates, I like to use surgical templates for pretty much all of my implant treatments. I've been to lectures where there's other surgeons talking, they go, oh, I never use templates, I'm really fantastic. I can put it in the right place every time. And every time you hear that, you've got to have some significant warning bells with regard to that, because there's nobody out there that's that good all the time that they can do that. Temporization is important. I get a lot of questions on temporization when I'm referred patients, and I go through a different selection of what they can, where patients are very concerned that they're going to leave the surgery or the office without any teeth, and so that needs to be addressed, and there's a number of ways of doing that, whether there's a bonded tooth or whether there's an Essex type splint or whether there's a bridge that can cover that area. I'm not a big fan of flippers or conventional dentures that press on the edentulous ridges, whether we've placed implants, whether we've done grafting or whatever. I think those significantly interfere with healing, so we need to have some other pre-organised way of temporising people. And in a referral practice like mine, we sometimes place those devices ourselves, or they go back to their dentist to have it placed. But they also need to know what the plan is. Like on a Friday afternoon when we've extracted a tooth and put an implant in, and they go, well, what am I going to have for the weekend, you know. And I work a little bit late on Friday, so most of the referring guys are already at the pub or out for dinner. So it's a situation where patients are concerned about that, and we like to address that, and we like to communicate with whoever referred the patient. That antibiotics. So if we're treating people in our clinic, and we use preoperative antibiotics for implants, and then another 5 days of treatment after that, particularly if we've done grafting. Analgesia is a big issue. People are concerned about how much pain they're going to have with treatment. Generally, I think there's less pain with having an implant than having a tooth extracted. So what I would say to people in a single tooth implant, a lot of the time, patients will take no analgesics at all, or they'll take something minor. They'll take some Nurofen, or they'll take some Panadol or some Panadine. Occasionally, you'll get someone who's a lot sorer than that. That's fairly rare, but we like to cover all those scenarios so there's less phone calls and less unhappy people in terms of their post-operative management. Anti-inflammatories are good if people, for example, have got severe asthma, then it's contraindicated for them to have anti-inflammatories, or if they've got some bleeding disorder, that's a contraindication. So we need to understand our patient's medical history, and then we need to understand, what they're capable of standing in in our treatment. So it's a bit different having an implant than having a class 1 filling. So patients need to understand that. Quite often I get questions on that, and they go, I'm a really fantastic patient. I sit in my dentist, and they do whatever they like to me, and I go, okay, well this time, we're going to make a cut in the gum, and we're going to raise the gum back a bit, and we're going to be drilling into the bone. It's a little bit more invasive than what you've had before. Are you sure you want to be totally awake for that? And they go, a lot of the time they go, no, I want to be a little bit sedated for that or whatever. So we don't want to get into the situation where we're treating patients and either you're uncomfortable or they're uncomfortable. I always remember we were running an implant training course one time, and the dentist brought along a patient who doesn't go numb. So all the restorative work they'd done on them, the local anaesthetic didn't work, and so that was not the patient to come along to do his first single tooth implant on someone who's got a history of not going numb in his clinic. So these are the sort of things that that may be obvious but aren't sometimes obvious. Our radiographic templates can give us a great guide in terms of soft tissue and bone deficiency. So here's where the teeth should be, and we can see this big gap in here. So I already know when I see that I'm short of tissue in there, and to get a good result, I'm going to need to do some kind of grafting in that situation, maybe soft tissue and hard tissue grafting. So looking at our workup and looking at the ideal position of the teeth is really important in giving us some good guide in that. As I said, checklist for components. This might seem simple, but this happens all the time where people don't have the right equipment. They measure up and they think all they order in from the company is one implant. Well, you need maybe more than that in terms of sizes and things like that. So I have quite a big inventory because I don't want to get short and have a problem with that, and I have lots of components, and I have all the screwdrivers and everything that need to go with that. So skimping on equipment, skimping on implants and restorative components is not a good idea, even though we have nice reps here who try their best to supply everything if we get into trouble. Antibiotics, as I said, we do use antibiotics. There's various different ones we can use. So we always use amoxil if they're not allergic. If they don't, we have fallback position of maybe using some clindamycin or something like that. So we need to be aware of that if you're treating them under local and you need to write a script for them beforehand, or maybe you have those drugs within your practice that you can administer to them. But it's not cool if they turn up for surgery and you've not organised any preoperative antibiotics and there's a bit of a panic sending someone off to the pharmacy to get those, and those sorts of problems do occur. Okay, there's various reports on this versus a single dose versus a week course. I tend to stick with the original protocol with that, where I give a preoperative dose and I follow that up post-operatively as well, and we don't see too many problems with doing that. So, and I think the more complex the procedure that we have, the more likely that we do need to have a course of antibiotics. So if we're doing some sort of bone grafting or soft tissue grafting with that, or they have diabetes, or they're a smoker, or they have some other risk factors, then we'll be much more likely to follow up with a course of antibiotics. Anti-inflammatories. Anti-inflammatories are good. They can be administered preoperatively with help with pain relief and that sort of thing. There is some issue. The orthopedic surgeons are not that keen on anti-inflammatory because it does interfere with bone healing. But I think in the dental arena, with implants and the good blood supply that we have with the jaws, I don't see that as a major issue. Naproxen's used a lot, and it seems to be that has less effect or negative effects on bone metabolism than some of the other anti-inflammatories. Psychological profile. Dental phobia is a big issue. You don't want, if you've got a dental phobic and we're starting to do some more invasive procedures on them, then I think it's probably better to maybe not treat them under local anesthesia. We don't want to get into situations where we can't complete the surgery. And the more complex the surgery, the more likely we are to opt for something with sedation. Oral sedation is very variable. The drugs are very different, and certainly weight has an aspect on that. So with oral sedation, that can be unpredictable. You could have a patient who's heavily sedated or hardly sedated at all. So my preference is to have IV sedation where the doses can be titrated and you have an appropriate level of sedation for people. And then as we get into more major procedures, we really want to look at having general anesthesia, or if they're a severe gagger or they're so phobic they can't keep still, then we need to consider having them right asleep for those procedures. So I'm not a big fan of oral sedation, so I'm not going to linger on that too long. Adequate local anesthesia. When you're doing surgical procedures, whether that's extracting of teeth or implants, they need to have more local anesthetic than you do for restorative procedures, and probably you should have something that's going to last a little bit longer. So with lignocaine, what you'll find if you're starting out with implant treatment, it's taking a little while, you've got lots of irrigation there, you're probably going to find the local anesthetic's going to wear off before you get the implant, and so consider using Marcaine, something a little bit longer acting would be appropriate for that. Instruments. I think instrumentation is important, and you need to do that. Obviously, we need a significant larger range of instrumentation if we're going to do implant treatment rather than other more simple surgical extractions of teeth. So having the right equipment is important, and understanding all that. I think when we teach implant training courses, one of the problems is the skill level of just basic surgical skill level with incising the tissue